Is it better?
Also,
Good.
I'm unmuted now. Yeah. Okay. So I'd like to welcome you all to Grand Rounds today. And for those that would like to receive CME credit, here's the CME number 47801. We have a number of upcoming special discussions and special talks. As you see here, we have Michelle Kittleson coming on the 10th, but before that, next week, Jeff, yes? Right, is Joe Wu for the Medicine Grand Rounds and the Calabrese Lectureship next Thursday. Special notice to all the fellows about the lunch on Thursday as well. Please RSVP to Dana Brenkel for that, and the lectureship on on Thursday, next Thursday. This Thursday. Yeah, 2 days. 2 days, right. Here are today's disclosures. So it's really my pleasure to introduce today's speakers. We have 2 fellows giving their third-year talks, graduation talks, thematically different but equally interesting. I told them both that I was going to give brief introductions because I'm saving my best material for 10 days from now for graduation. Sean Park is currently a PSTP fellow in Dr. Jerry Schulman's laboratory, focusing on cardiometabolic health and cardiometabolic signaling. I will give your full bibliography at graduation, but suffice it to say, he comes from a wonderful training background, including an MD, PhD in training at Vanderbilt. Kene Mezwe will be discussing EP services in low-income countries. His interest and his passion is in global health and electrophysiology. So I know they both have a lot of slides and a lot of interesting topics for discussion. So I'll turn it over to Sean now to begin today's grand rounds.
All right. Okay. Thank you, everyone, for the opportunity. Today, I'm talking about liver-targeted therapeutics as a new frontier in cardiometabolic health. No disclosures. And so the objectives for today's discussion are to, one, define cardiometabolic syndrome and discuss prevailing therapeutic strategies, to discuss the role of insulin signaling in cardiometabolic disease, and explore therapeutic potential of liver-targeted uncoupling agents for treating cardiometabolic disease. So cardiometabolic disease is a chronic and progressive condition. Oh, I'm on the wrong slide here. It's a chronic and progressive condition, and is characterized by a constellation of metabolic abnormalities, including insulin resistance, obesity, diabetes, hypertension, dyslipidemia, and it's defined as having three of the following: elevated fasting blood glucose greater than 100, low HDL-C, elevated triglycerides, elevated waist circumference, or hypertension. And its prevalence is estimated to be between 35 to 40% in the United States, and this parallels the rise in obesity that we see. So this is a map that color codes the self-reported prevalence of obesity in the United States in 2011. And as you can see, most of it is yellow, which corresponds to 25 to 30% of BMI greater than 30. And by 2023, there was a substantial rise in obesity. And you can see that there's no state or territory with less than 20% prevalence of obesity. And there's over 17 states with greater than 35 to 40% obesity, which is quite staggering. So cardiometabolic syndrome is a leading cause of morbidity and mortality. And it's primarily driven by the trifecta of coronary artery disease and its sequelae, diastolic heart function, or HFpEF, and then metabolic dysfunction-associated fatty liver disease and its consequence of steatohepatitis and fibrosis. And so therefore, it's no surprise that elevated BMI is associated with an increase in all-cause mortality. You can see on the x-axis is BMI, and on the y-axis is hazard ratio for mortality. And this is whether you compare cancer, cardiovascular disease, strokes, et cetera. They all have this increased mortality with an increase in BMI. And so while nutrition, exercise, weight loss have all been tried, they have not been overly effective in our general population. And to date, it seems that GLP-1 agonists are becoming major players in the weight loss and cardiometabolic treatment. So GLP-1 agonists are associated with significant weight loss. What we see here on the left side here is up to a 15 to 21% reduction in weight loss with semaglutide, which is GLP-1 alone, versus the tirzepatide, which is in combination with the GIP agonist. And with that, we've seen significant improvements in cardiovascular outcomes, including non-fatal MI, cardiovascular death, and non-fatal strokes. And so GLP-1 agonists have demonstrated widespread benefits. And what I'm showing you here is a forest plot, and it's suggesting that there's an improvement in a lot of different conditions, which are not just cardiovascular, but anything from shock to neuropsychiatric diseases, including things like schizophrenia, bulimia, addiction, to heart failure. But there are some adverse effects that limit their chronic use, including mostly GI side effects that limit their tolerability, but also they have been found to have, one, patients seem to not enjoy not eating, but two, it is also associated with reduction in lean mass or muscle mass, which is not probably appropriate for the aging population. So alternative strategies will likely be needed for combating cardiometabolic syndrome. And I think at the heart of that is the energy balance. And simply, it's just energy in versus energy out. And so if there's other ways of modulating the system that maybe do not have those side effects, this may be the optimal way of doing this. And so with current strategies with caloric restriction or appetite suppressing drugs, we often see a return to weight gain. But I think the optimal strategy may include both maybe some suppression of appetite, energy enhancement, increase in energy expenditure, as well as something that maybe does not result in a reduction in lean mass. So the objectives, the second objective I want to talk about, because I think this is critical to understanding the development of novel therapeutics in this space, is insulin resistance in the development of cardiometabolic syndrome. And so I won't go too in depth, but I just wanted to start with an insulin-sensitive, insulin-resistant state and how these may modulate cardiometabolic disease. And so on the left side, we see the insulin-sensitive state. With insulin, you have activation of tyrosine kinase receptors that autophosphorylate and cause activation of AKT and a significant number of downstream signaling events, some of which include an increase in pyruvate or glucose oxidation, but also a reduction in glucose production. Specifically, this cell is a hepatocyte or liver cell. In the insulin-resistant state, Dr. Shulman's lab and others, and many others believe that there are these pathogenic lipid mediators that are diacylglycerol, specifically the stereoisomer SN12 diacylglycerol, that results in activation of PKC epsilon, and this reduces insulin-mediated signaling. And when insulin binds to the receptor, you're not able to sufficiently activate downstream signaling, and therefore you get a reduction in the amount of pyruvate or glucose oxidation, and you actually have an increase in things like hepatic glucose production, which then results in hyperglycemia and can ultimately lead to diabetes, or increased VLDL production, or the atherogenic dyslipidemia, or even just fat within the liver itself, which is the hepatic steatosis, and then ultimately the MASH. So the next thing I would like to talk about is the potential for liver-targeted therapeutics for treating cardiometabolic syndrome. And dinitrophenol has been something that has been used for treating weight loss for over a century. And it does have pretty significant effects on weight loss. Studies initially from munitions factories, they found that these people, the workers in the factory, would lose a lot of weight. And it was from working with the dinitrophenol and then to make TNT. And so when they found this out, they started to advertise the use of this compound or its derivatives. And these are some examples of the advertises for losing weight. However, they also had significant side effects, and whether it's from DNP itself or whether it's from some of the solvents that it was in, it did result in significant cataracts, which is why it was ultimately pulled from the market. But it does also have other side effects like increasing body temperature, hyperthermia, for example. And so physicians at the time, this is a quote from a fairly old journal, said, obesity has contributed to heart disease and diabetes, and weight reduction was no longer a fad, but a health necessity. And so it's no surprise that this physician began using dinitrophenol in his practice. And this was very forward-thinking. However, I think it's important to understand how this works and how we can improve upon it. And so on the right, I have a figure here that shows the electron transport chain. And all I want you to really take away from it is that there are substrates like glucose and fatty acids that come into the system that are used by the TCA cycle. So if you have fats that come in through beta oxidation, you can supply acetyl-CoA to the TCA cycle to generate these protons. And when you have a lot of protons in this intermitochondrial membrane space, it drives ATP synthase from a high concentration gradient to a low concentration gradient to generate ATP. Now with uncouplers, or things like dinitrophenol, it's essentially a chemical uncoupler. This is what some people think. And it actually just dissipates the gradient by bringing over these protons through the drug. And therefore, it revs up the TCA cycle to burn more fat, to bring in more acetyl-CoA to generate that proton motive gradient that then is able to sustain the ATP production. And this essentially results in a lot of fat loss. DNP, however, has a rather narrow, why is it not working? Has a narrow therapeutic window, as we saw, based off some of those side effects. And the modification of DNP has resulted in the generation of liver-targeted protonophores, which is what Dr. Shulman's lab and his colleagues have been doing for some time now. And the administration of these liver-targeted protonophores have been found to be safe in preclinical studies, as well as now some human studies. And so liver-targeted protonophores are suggested to improve cardiometabolic health through a number of mechanisms. And so I wanted to just briefly discuss those. And we can start with that with the increased utilization of fat. So you increase fat utilization, you can remove these diacylglycerol, specifically the pathogenic SN12 DAG, which removes the inhibition of PKC epsilon on insulin signaling and thereby decreasing hyperglycemia. Now, it also enhances peripheral insulin sensitivity, such as in muscles, by doing something very similar. It allows for increased glucose uptake and utilization, and it also therefore reduces VLDL production, which can then result in potentially reduced cardiovascular disease. Now, TLC 1180 is a novel long-acting liver-targeted protonophore that Dr. Schulman and his colleagues have developed, and they have greater than 30-fold potency over the nonspecific DNP scaffolds. And so what I'm showing you here is some in vitro data looking at various kind of outcomes comparing TLC 1180 versus DNP, and you can see that this TLC compound is much more potent, and it is long-acting. It only needs to be in mice treated dosed twice a week. And it results in specifically increase in the TCA cycle here, 0.11 micromolar versus 39. So you can see that you don't need very much of it to sustain the same effect that DNP would have, over a century ago. So to do this, I evaluated TLC 1180 in a preclinical model of diet-induced obesity. So I had mice that were treated on a high-fat diet for over 28 weeks and began treating them with this compound twice a week. And I completed a number of metabolic phenotyping evaluations on them. And first, what we can see here is that this is on the x-axis number of days after treatment and total body weight. And you can see that there is a reduction in body weight by about 20% compared to placebo in the DIO model of obesity. So with CRMP, which was the earlier derivative, we had some improvement, but not improvement in weight. And so because this compound is much more potent, you're able to begin to see these reductions in weight. Now, this reduction in weight seems to be a reduction in fat mass over lean mass. This is percent of body weight fat mass versus lean mass. And you could see a reduction in fat mass with an increase in fat mass such that over a period of time, there's actually a preservation of lean mass. There's an increased lean to fat mass ratio, which is kind of different than what we have seen with GLP-1 agonists. It also increases energy expenditure. So this is putting mice in indirect calorimetry devices that allows us to kind of assess how much energy they're producing based off of kind of the heat they generate in a way. And we see increased energy expenditure in these mice, whereas GLP-1 agonists, there's a divide in the data, but a lot of data would suggest that GLP-1 agonists do not actually have much impact on energy expenditure. It's more on food intake, which is significantly down in GLP-1 agonists. With TLC 1180, it does not seem to change food intake. It also improves insulin sensitivity. This is insulin with the treatment is significantly lower, so you need less insulin to maintain the same plasma glucose compared to vehicle-treated animals. And HOMO-IR is just a model of insulin resistance and kind of suggests, again, that these mice are going to be more insulin sensitive with treatment of 1180. It also reverses hepatomegaly. So this is liver weight to tibia length, and it significantly reduces this. It also reduces hepatic steatosis and almost normalizes some of these injury markers that to me is pretty astounding. So these are again mice that have been treated for high fat for 30-something plus weeks, I think almost 40 weeks, and you're able to reverse some of these findings. It also improves dyslipidemia, so total cholesterol is reduced, LDL is reduced, and there's a trend for a reduction in plasma TGs as well. So I next want to evaluate the effect on cardiac performance. And so one way to do this is to use exercise stress tests, or in this case, it's more of a graded exercise test that allows me to evaluate for VO2 max, among other parameters. And so on the x-axis is time, and on the y-axis is both speed and degrees. And so as time goes on, you increase both the speed and the incline. And you can see in the DIO TLC treated animals, there's an increase of VO2 max, which is associated with oxidative metabolism that continues far longer than vehicle-treated mice. And this is just an example of what this looks like. You can see the mice running on the treadmill. And based off this, you can kind of quantitate VO2 max and things like endurance. So max speed, they're able to go faster because they're able to run for a longer period of time. And so it seems that TLC 1180 does improve cardiometabolic health in these preclinical models. It reduces liver size and reduces hepatic fat, and thereby it is able to remove this SN12 DAG and the inhibition of PKC epsilon to therefore reduce hyperglycemia. We're able to reduce the dyslipidemia. And also, as I already said, we increase the insulin sensitivity in the periphery. I didn't show you that specific data, but we also have data for that. But it seems that there is an improvement in cardiopulmonary fitness as well, based off exercise, the graded exercise test. And so the question is how? And there's quite a debate in the field, but what I have here is a cardiomyocyte. And what I want you to take away is there's many metabolites that it can use to generate ATP. Glucose and fatty acids are primary, predominantly fatty acids, and they can go into the system to make acetyl-CoA to then generate ATP. Now, heart failure with preserved ejection fraction is associated with a reduction in pyruvate oxidation. There's less pyruvate, glucose to pyruvate coming in to generate acetyl-CoA, and therefore that cannot be oxidized to generate ATP. Now, SGLT2 inhibitors and GLP-1 agonists have both been shown to improve pyruvate oxidation. Therefore, improving glucose oxidation may be sufficient for the cardiac benefit seen with these drugs. And so I wanted to evaluate what would happen with TLC 1180, and therefore I used a stable isotope, so it's a labeled glucose, and then I can track what happens to that glucose in awake animals. So they're infused this isotope, and then at the end of the experiment, I evaluate in the heart the amount of glucose that ends up as pyruvate or lactate or alanine versus if it goes through the TCA cycle, it would generate glutamate. And so if you have a lot of glutamate generation, then that would suggest that there is high levels of PDH or pyruvate dehydrogenase activity, such that glucose oxidation is closer to 100%. If there's a lot of fat oxidation, then you'd have less of this, and this would be closer to 0. So first, with the high fat alone, you can see here VPDH to VTCA. With the low fat diet, it's about 60%. With high fat diet, you can see that there's a significant reduction in cardiac insulin-stimulated pyruvate oxidation. So here, PDH is down such that you have a reduction in the M+2 glutamate and an accumulation of one of these three mediators. With 1180, we see that TLC 1180 is able to increase that VPDH to TCA such that you have an increase in pyruvate dehydrogenase activity, resulting in increased glutamate with a reduction in the accumulation of the pyruvate or glucose. And this is similar to what we see with the semaglutide or the GLP-1 agonist alone. Therefore, in conclusion, the rise in obesity and associated cardiometabolic syndrome is a massive public health threat. And while GLP-1 agonists have been transformative in this, there is room for improvement. Insulin resistance is a critical mediator of cardiometabolic syndrome, and therefore, with liver-targeted protonophores, which have been shown to be safe, they result in weight loss, and they may improve cardiometabolic health. TLC 1180 specifically is a novel liver-targeted mitochondrial protonophore in preclinical development, and it significantly reduces weight, reduces hepatic steatosis, reduces atherogenic dyslipidemia, and also is suggested to improve cardiopulmonary fitness, evident by the VO2 max endurance, and then also the signature for increasing pyruvate oxidation. So future directions, I'd like to investigate the mechanisms by which this uncoupling improves the cardiopulmonary fitness, specifically at the level of how is it increasing myocardial pyruvate oxidation in the insulin-resistant state, and then evaluate the efficacy of these in preclinical models of heart failure with preserved ejection fraction. Lastly, I'd like to acknowledge Dr. Shulman for providing me the opportunity to join his lab with pretty minimal background in metabolism at all, and the entire lab for being extremely helpful in kind of getting me going and helping me with many of these experiments. In the Division of Cardiovascular Medicine Fellowship Program, Dr. Millard, Dr. Young, and the PSTP, and the T32 in the Liver Center, which has been helping provide funding for me as well. So with that, I thank everyone and take questions.
Oh, thank you. So, Sean, that was an incredible, just the amount you've accomplished in what has it been, 4 or 5 months, right? Almost a year, almost a year in the laboratory is just tremendous. I think we'll take this opportunity, because these presentations are not thematically related, to ask maybe two or three, four questions up front. I think my first question is, obviously the question comes up about cardiomyocyte ROS, right? I mean, is this protonophore associated with significant ROS production? Is that going to be deleterious in the long term? What are your thoughts on the potential deleterious effects of the uncoupling that you're inducing?
So I haven't specifically looked at ROS in this model, but I would think that it's actually down. I would need to review that literature, but yeah, I would suggest that it's actually reduced in these models. But I can give you the exact details at another time.
Yeah, but it's actually modified not to get to the heart.
Just to follow up on that.
Yeah.
Sorry. There's ROS is normally generated through electron transport through the mitochondria. That's a constitutive ROS activation that's important for cellular health often. And, it's a balance of how much ROS is made. So I guess that would be the minor concern, I suppose, if you're shuttling rapidly as your proton gradient changes and you're pushing through the electron transport chain, could you actually be generating more ROS that way? Does that paradoxically happen? Jerry, you said ROS is down. Sean?
Yeah, I mean, again, I'd have to look specifically at that, but I haven't looked with TLC 1180, but I believe with the prior data, it's not increased.
It's been looked at previous CRFP actually looked at this, and there's no difference looking at ROS markers, no difference or actually reduction. And people who study uncoupling for a living actually show there's actually less ROS when you actually add classic uncouplers. Usually, most of your ROS can be generated by reverse flux through SDH. That's what Michael Murphy has shown, and under these conditions, you actually have less of that.
Really wonderful to see this, starting to play out, and congratulations to Jerry and to you and everyone. You didn't show, I know it's hard to evaluate heart rate in mice, but did you notice any changes in any hemodynamic features? It's great to see the cardiopulmonary fitness data, but any signs of concern around increased heart rates or anything with these in these animals without activity?
No, I didn't see that. And I didn't do any sort of telemetry or any sort of heart rate monitoring, but there are preclinical studies that are being done in primates as well that have, to my understanding, not shown any adverse events in terms of tachycardia. Although I know the earlier DNP, there was some tachycardia that could be seen.
And so I was just, and I'm a simple country cardiologist, I don't understand all the biology, all that perfectly well, but the ATP availability goes down.
Availability of ATP.
In the models that you showed, is that correct?
I don't think so. No, I think that the ATP is sustained at a certain level. It's just that you're going to have more fat burning to generate that proton motive gradient to maintain that ATP.
Okay.
So ATP I don't think is changing. It's just that you have more fat being oxidized to maintain the gradient.
Okay. And maybe one last future direction. I think it would be important as this progresses to look at ischemic animals, those with cardiac ischemia particularly, to make sure that you don't uncover some concern before it goes too much further, because I do worry a little bit about racing hearts and being able to run out of the fat in an ischemic environment. I think it's something that be just probably on your list of things to start evaluating with a HFpEF model. Sure.
That's a good suggestion. Thank you.
Yeah.
Can I ask you a question?
That's a great segue, talking about heart rates, to Dr. Meswe. And I think we'll bring you back up at the end for further questions, because I think there's a lot here to explore. And just congratulations to you again for the multidisciplinary nature of your work, as well as the broad group of investigators and investigations you put together. That's really exciting. So Dr. Meswe, the floor is now yours. We're excited to hear about your work on electrophysiology. And
oh, no, I don't think so. Yeah. Thank you so much, Dr. Freeman. Hi, everyone. Good evening. So my topic today is EP services in low-income countries. Is it a luxury or a necessity? And my faculty mentor is Dr. Freeman, who is here. So I don't have any disclosures yet. My learning objectives are my learning objectives today are to explore the gaps in EP services in low-income countries with a focus on Africa and the Caribbean, which is kind of where my heart is, and to discuss the challenges that we face in trying to get these services, and also to outline some winning strategies that I've observed that can expand these services. And, before I go into the topic, I just want to say that, my, desire to become an electrophysiologist actually happened while I was in fellowship. And, I remember a comment one of my colleagues made. He said that, EP is kind of a luxury. And it got me really thinking, because sometimes that's how we perceive it, in the sense that, a lot of services aren't urgent in a sense, sometimes at night. But at the same time, a lot of hospitals can do without an EP service because they can refer somewhere else. But that's in America. But when you're in a place where there are no EP services for millions and tens of millions of people, I think that's where EP probably becomes a necessity. And that's kind of what I'll explore. And at the same time, I also talked with one of our senior colleagues who was once here, but she's a global public health person. And she was saying that, Africa has bigger problems. But I think we can walk and chew gum at the same time. And that's kind of what I'm going to focus on in this presentation. So the first thing I want to talk about very briefly is that EP therapies are effective. And I don't think anybody's going to argue with me about that. So I'll start from the very beginning. So maybe about 100 years ago, Liddell in Australia and Hyman in the US here were the first to demonstrate that you could actually pace the heart. And they both had, machines that basically had needles going through the intercostal space to directly, basically pace the heart. And the machine I have here is Hyman's machine. For some reason, Liddell's machine is not, you can see the picture on the internet, but Hyman's machine had a crank, and you basically would wind the crank, and then you basically generate the pulse that, the needle would deliver. And actually, Hyman was the one who first used the word pacemaker, and we've used it till now. So and since this discovery happened, we've then had like a paradigm, series of innovations over the last nearly 100 years, where we've basically made the technology better. So we started with AC-powered pacemakers by Foreman, and then Lehigh and Bakken in Minnesota. We're able to make it wearable, but still had a battery. And then in 58, Swedish innovators were able to implant the first pacemaker. It only lasted for like 2 weeks, and then they had to take it out. But then we'd be able to iterate these devices. And now we have leadless pacemakers. And in the future, we think that they're going to be just really tiny microchips that we could place. But the thing about these pacemakers is, nobody, I think, argues whether there's effectiveness with them. Just a couple, maybe about 20 years after they were established, it was very clear that they had life-saving benefit. And this study I have here is from, it's one of the earlier studies from Malmo, where they just looked at a year of people in a series with pacemakers, without pacemakers, and you can see the obvious benefits that they had in this study. Prior to this, when patients had bradycardia, sinus bradycardia from sinus node disorder, or AV block, the only options they had were things like atropine, ephedrine, or a combination of those drugs. But with the establishment of pacing, you basically can give those patients another shot at life, basically. I don't think anybody does trials now where we randomize patients to pacemakers or no pacemakers, because we have established that this is life-saving therapy. And just for fun, if you actually had to calculate the number needed to treat in the graph on your left, that's this graph, it's probably like 3, which is what we think it is. Also, I think quality of life also with pacemakers has also been established. And yes, pacemakers have some side effects, as it were, to them, like the risk of infection when you have leads in the body. But then there's a big quality of life improvement to a lot of patients who, with both sinus node disorders and AV block. I deliberately chose this study from India because it was actually one of the first studies that looked at the impact that pacemakers can have on caregivers. So we always think of the patients, but sometimes we don't even think about the people who take care of these patients. And here they use this Zarit score. A negative score here indicates improvement in status for caregivers in this situation. Of note in this study, again, India, I think, is more of more advancing country, but only one out of 6 patients who needed pacemakers in India were able to get one in this study. So other innovations in the EP world have followed shortly. So ICDs and CRT devices, have become very established, and we have clear guidelines where they're appropriate to be implanted. And the number needed to treat for some of these devices is as low as 6. In fact, the number needed to treat for sudden cardiac death is as low as 2 to 3 for ICDs. We have radiofrequency ablation, which first started as DC ablation in the early 80s with Mel Scheinman, and then later on, still Mel Scheinman introduced us to RFA, and this has been life-changing for a lot of patients who have been debilitated by different types of arrhythmias, and so the ability to use catheters to ablate arrhythmias is definitely life-changing. And then the left atrial appendage occlusion devices are a great innovation that has also stood the test of time in the last 20 years. And so I'll switch gears now and talk about low-income countries. So what are low-income countries? So the classification that has countries divided into high-income, low-income, middle-income actually started around 1988 by the World Bank. It was the threshold were chosen based on a mix of economic analysis and policy relevance, and the initial cutoff between the income groups was chosen to reflect significant economic differences between countries, particularly in terms of access to resources, infrastructure, and markets. And so we have this classification of countries into low income, lower middle income, upper middle income, and high income. And as you can see, most of the Western European OECD type countries are in the high income group, and a lot of the countries in the low income group are in sub-Saharan Africa. And one thing I'll just briefly talk about is the characteristics of low income countries generally. If you lump China and India in that group of low-income countries, because when you look at per capita income, it's usually much lower. 85% of the global population is in the mix. If you take India and China out, probably about 40% of the global population is in that low and middle-income group. There's usually a lot of high-income equality. There's a lot of, there's a younger population, and then there are higher poverty rates. And when we talk about poverty rates, sometimes it's really glaringly severe. And you find out that lots of patients lots of people in these countries get to live on less than $30 a day. Another thing I just realized when I looked at this map is that the map of low-income countries kind of almost overlap conflict zones. And that's why I don't think you can really separate like politics from economics, and that's the reality. And so ending wars is probably going to be very important if we really want to, broach the gap. But today my focus will be on sub-Saharan Africa and the Caribbean. And there are also other low-income countries in Asia. And so I'll shift gears now and talk about cardiovascular disease and arrhythmias in low-income countries. So I think, one thing that we started seeing, and we've kind of seen this for, more than a couple of decades. So this is data from the Global Burden of Disease as far back as 2008. We're realizing that, low and middle income countries kind of have this double-edged burden where they're exposed to both a lot of mortality from communicable and non-communicable disease. And chief among the non-communicable diseases is actually cardiovascular disease. And in this graph, you can see that the mortality in Africa from cardiovascular disease, non-communicable disease is actually higher than what you get in the high-income countries. And then even in a recent global burden of disease study from 2023, you can see that the darker shades of blue are actually where you have more mortality due to cardiomyopathies. Again, a lot of these cardiomyopathies haven't been well typified and diagnosed because of lack of imaging and other facilities to classify them correctly. But still, that fact that there's so much more burden and mortality from cardiovascular disease in low-income countries is really, really startling. And a lot of authors have actually seen that this also will translate directly into having more patients who need arrhythmia care, because we know that when patients have cardiomyopathies, they're likely now to have other issues related to arrhythmias, including atrial fibrillation, ventricular tachycardia. And, and I think this is something that needs to be addressed. Unfortunately, there's a paucity of data in African countries because there's a lot of registries are not, don't cover this aspect. There's a big study called EMOTEP that I'm hoping, it's just reporting gradually now, but they basically covered a lot of cardiomyopathy in Southern Africa, and they're expanding to other parts of Africa. And we're hoping that that registry in the coming years will give us more information on that, the arrhythmia burden, in Sub-Saharan Africa. But one of the studies I found was from Dr. Amy Bonney's group. No, Dr. Amy Bonney is a Cameroonian cardiologist who's done a lot of epidemiological work. And, he did one of the first sudden cardiac death registries in Cameroon. So they picked a district in Douala, and they basically over a year just wanted to look at all the deaths in that district. And they found that almost 10% of all the deaths were sudden cardiac death. And I think what strikes me is that the median age of patients having sudden cardiac death there was 46. So I think there's a high arrhythmia burden in most African countries if we care to look. But unfortunately, we don't have so much data, and that's one of the focuses of work in the future. Next, I'll talk about the lack of EP services in low-income countries. I think this is the one that shocked me the most, is when you look at pacemaker placements per year, this is as far back as 2017, you can see that there's such a stark difference between the number of pacemakers placed in the high-income countries and the pacemakers placed in the low-income countries. And, I think so far in my reading in medicine, I've never seen a disparity where you're looking at 10,000 times. I think there's nothing special about Africans that they're not going to have conduction disease. And the fact that they don't have people that can place pacemakers in these countries, I think is very, very worrying and very important for us to address. And what really drives the fact that we can't place pacemakers and we can't have EP services in this country is that we just don't have the EP facilities. And even in Africa, there's a big disparity between parts of Africa. So Northern Africa, for example, has a bigger EP presence, and South Africa has a big EP presence. But then the vast majority of Africans in Sub-Saharan Africa don't have access to EP services. And one of the things that we'll talk about is how even within Africa, we're having Africans helping Africans, basically. Most times devices in African countries are placed by interventional cardiology because there's a good interventional cardiology presence now, cardiac surgeons and visiting teams. But then there's poor after device placement care. And so the figure on the right is a figure that basically shows you the EP labs in African countries and those that have EP services that kind of operate on a weekly basis. And you can see in places like Egypt and South Africa, you have almost 20 labs that are fully functional. But then you don't have an EP presence at all in Nigeria. Nigeria is about 250 million people. I have a friend who is an interventional cardiologist and he places devices, but he's very willing to learn, and he's actually started learning ablation, which is amazing. So I think there's so much room to grow, so much room to help, in this field. I also wanted to talk about this PASCA survey in 2018. And for this survey, within 3 weeks, 1 or 2 cardiologists from 31 countries were contacted, and 23 of them provided data. And they were able to tell us actually how many pacemakers were being placed in their countries. And we cross-checked this data with CID manufacturers. And you can see that there's such a big disparity between the Northern African countries like Tunisia and Algeria and South Africa and countries in Sub-Saharan Africa. And for me, it kind of hits a little bit close to home. So this is my dad, who is my hero. Dr. Miller was asking my class today, who are the heroes? And Dr. Miller, this is my hero. And my dad is, he was a transmission electrical engineer for many years. He's retired for about 12 years now. And he's 73. And he lives in Nigeria with my mom. They're both retired. They live in this part of the country called Benin, which is where that blue dot is. And, they have their fair share of cardiometabolic issues. But, sometimes it worries me that if for any reason my dad gets AV block, he lives 200 miles from the nearest site that can place a device in him, that does it regularly. The sites that do it regularly now are in Kano, Abuja here, Enugu, where I went to med school, Port Harcourt, where my friend the Dafe stays, and then Lagos, where there's a good number of EP labs interventional cardiology labs in Lagos, and that's where a lot of pacemakers get placed. But I just find it, sad in the sense that there is really no help, and that's why people have sudden cardiac death, and then nothing really is done because it takes time for them to get transported to any of these centers. And I think the biggest challenge is costs, and these devices are very expensive. So this is just a gross estimate of what some of these devices cost. And, a lot of patients have to pay cash for whatever services are delivered. And I think that's the big limitation, especially when you talk about the GDP per capita in these countries. There's also a lack of public insurance that tends to cover like devices. So most times insurance products will cover certain medical type services and medications, but they will not cover surgeries and devices. And I think that's one of the big challenges. And then other challenges are things that we've probably heard before. You know, we talked about lack of manpower. I think one of the things that we're seeing and people are realizing is that there has to be a shift from, you know, public administered services to private services, because private services tend to be more efficient. And, you know, there's also a very interesting aspect that I will talk about a bit later, where there's lack of government support. And so you find out that providers who want to try and establish some of these private services will face challenges of just importing some of the products and devices for the labs. So what are the winning strategies? So one of the strategies I want to talk about is the reuse of devices. It's not a new idea. It kind of started in Central America in the 80s, and a review of, you know, a meta-analysis that tried to look at whether these devices are safe, you know, showed that, you know, for the best part, you know, the infection risk is actually not really that high. The bigger problem is that there is a risk of malfunction, which could be 6-fold greater in reused devices. And often the problem was the header set screw, which is the portion of the pacemaker header which tightens the pacemaker lead in place. And so Dr. Tom Crawford and his group at the University of Michigan were able to start this collaboration called My Heart, Your Heart. And I think we heard about it last year when Dr. Kim Eagle came around to give us grand rounds. You know, he talked about a study that they did that ended up being reported in as a late-breaking trial in the AHA later that year. But it was basically a collaboration between the University of Michigan, an implant recycling Detroit-based recycling company, the World Medical Relief, and any scientific. And I'll just briefly go through what they do. They realized that because in America, we implant about 250,000 pacemakers annually, and a lot of these pacemakers, patients die, and basically the pacemakers still have life in them, basically. We could actually repurpose these pacemakers and donate them. And the idea is that we can get pacemakers less than $100 to patients in low-income countries. And so I wouldn't go into too much detail about how they go about doing that. And, you know, maybe in the question time, we could talk about it. But basically, you know, World Medical Relief receives the donated pacemakers from the crematorials, and then it's sent to actually any scientific, which is based out of Waterbury here in Connecticut, where there's some device cleaning and contamination. And then it's sent back to Detroit, where there is electrical testing, and then it's repackaged. So I can always come back to this, but basically this is all the programming they do. So I want to talk about My Heart, Your Heart, which is the RCT that was carried out. This project actually started in 2010 by Dr. Tom Crawford when he was still a fellow, and he's now a full professor at the University of Michigan. And it's wonderful. I was able to meet him this year at AHA at the HRS, and he was very fortunate to get slides from him. But basically what they did was they wanted to show and demonstrate that in an RCT, in a randomized control trial, you could actually show that these devices were functional and didn't have an infection risk. And so they randomized almost 300 patients to receive new devices versus receive these reconditioned pacemakers. And it was designed as a non-inferiority trial, and it was single-blinded, and it recruited from around May of 22 to June of 2024. And that's Don Crawford in the picture there, and that's one of my colleagues, Dr. Emmanuel Edafe, is an interventional cardiologist in Port Harcourt, Nigeria. And I remember calling him and asking him about the trial, and he was like, yeah, I was one of the top implanters for the trial. So that was really cool to find that global collaboration. And I also remember that Dr. Velasquez has done a lot of work at Eldoret. So when I saw Eldoret on that list, I was very happy. That was one of my fellows. Oh, he was one of the fellows. Awesome. And so these are the baseline characteristics of patients on the list, and it's not that different because it was a randomized trial. And here's the primary outcome, and this was what was presented at the AHA as a late-breaking trial last year. So after 90 days of follow-up, they found that actually infection risk was actually lower in the group that got the reconditioned pacemakers, so the group in blue. And you know, they basically met their non-inferiority endpoint very easily. And you know, they didn't find and then when you also look at other complications and malfunctions, they didn't really find any significant difference. And I think this is very reassuring to us that this could be a strategy. The problem, however, with this strategy is that it's raised a lot of ethical challenges. You know, the idea is, you know, why are we getting donated? Why are we getting reused pacemakers versus brand new? And some people are saying other people's lives different. But the issue is that I think it's a practical solution that I think a lot of governments, at least those governments that participated in the trial, have agreed to. And I think patients are clearly explained, the pros and cons of using these reused pacemakers. The next strategy I want to talk about is this issue of training, which is very, very important. And like I said, the lack of trainers is it's such a difficult hurdle to overcome sometimes, because if there's no one there that can train someone else, then you can't really get the ball moving. So, for example, I remember when I was at HRS, I talked with one of the EPs from Egypt, and they have like 100 EPs in Egypt. So. And the reason why they have that is that over years, they've just been able to train more people. And so my hope is that, PASCA, which is the Pan-African Society for Cardiology, has started, aggressively trying to get more training done. And thankfully, because of the online facilities that we have now, we can actually get more continuous training for people. And then they can get some hands-on training by doing some work in the bigger centers in Egypt and South Africa. And so I think there's a well-established system now that's kicked off around 2016 and is beginning to yield some fruit. And this was when I was at HRS last year, and I was with Dr. Mervat, who is the outgoing African Heart Rhythm Association president, and Dr. Shogade, who is the incoming African Heart Rhythm Association president. Another thing that is potentially a very cool solution in Africa is actually left atrial appendage occlusion devices, because these have been shown to at least get you the same level of prevention, stroke prevention for stroke, as oral anticoagulation. But oral anticoagulation is very expensive and has to be taken for life. And so studies upon studies have shown that actually there is cost benefit compared to taking anticoagulation. And in Africa, given the fact that we already have a lot of places that have fluoro and have places that can do TEEs, this could actually be a possible solution for patients, not just patients who have bleeding risk like we do here in the West, but even patients who don't have bleeding risk. It's a potential way of stroke prevention in those countries, given that we probably have the facilities to do that. And then another important, winning challenge I've seen is also just the interest of people. So Dr. Mel Scheinman is one of our heroes in electrophysiology. Who basically pioneered radiofrequency ablation. And he's basically been able to donate a lot of his time and resources to like establishing care. And so basically just having people with interest who can devote a substantial amount of their time, maybe 20%, 10% of their work life, to teaching and practice in developing country might be also another way. One of the places that Dr. Mel Scheinman focused on was Cambodia, where there were no devices placed in 2013, for example. And today they're placing about almost 300 devices with 6 different implanting centers. And that, I think, is the power of people just being able to devote some time. And that's one of the things that I've seen that has been recently very, very fruitful is this global cardiovascular collaborative, which involves like Mel Scheinman's foundation, the Cardiovascular Education Foundation, and so many other foundations in Africa. And they're trying not to duplicate work, but trying to coordinate work together, to go into places, to establish teams, and to spend some time with people to do some training and also place some devices. And I think that in time, the future tells me that there's a lot of hope. There's a lot of opportunities for expansion to bridge that 10,000 times gap that we saw earlier. I think mHealth is going to be very important, and I think, monitoring is going to also get closer to people. So, for example, the cardiac device is actually at that price point now where we can use it to do more effective monitoring. I want to talk about what I learned in Jamaica. So I want to say thank you to Dr. Miller and Dr. Velasquez. They sponsored me they sponsored a 3-week elective for me to spend some time with the Heart Institute of the Caribbean in Jamaica. So Jamaica, some people think is a high-income country or middle income, low or high middle income country, but it's actually a country where there's a lot of disparity because you have really rich people who, come there to vacation, but then you have a lot of people who just can't afford care. And so it was really, really interesting to spend some time there and to see what, is possible there. So the Heart Institute of the Caribbean is a private facility established in 2005 as an advanced cardiac hospital in Kingston, Jamaica, and he offered imaging, cardiac ICU, interventional, and cardiac surgical services. And what I kind of had learned, I learned so much there. I saw a lot of late presenting cases. I saw a 9-centimeter abdominal aneurysm, which is not connected really to cardiology, but again, but again, in a very young population. And I think that to me is very worrying. And that's where, a lot of benefit can be gotten if we can, if we do care. One thing I realized also is this issue of the private versus public dichotomy, and the difficulty in setting up a private establishment in the country where the government isn't really trying to help you, basically. And I would say, I was able to talk with providers in the public system, talk with providers in the private system there, and to see that, if we can get governments to encourage private enterprise, I think it will make a big difference in getting care to people. And I was able to make new friends, colleagues, and collaboration. So a remote ECG reading program has started already. I'm going to be taking some of those EKGs on Thursday. There's a cardiomyopathy clinic that is in collaboration with Dr. Miller. We're hoping that in the future, a complex arrhythmia program will be planned. So in summary, I talked about EP services being very effective at treating cardiac disease. There's a big gap. That 10,000 thing still starts in my head. Some of the challenges that are there to bridging the gap, which include costs and availability of training, and how reusing IC pacemakers can help us bridge the gap. So I'd like to say a very big thanks to Dr. Freeman, who helped to proctor me for this grand round. And Dr. Freeman also spent some time in Africa when he was an undergrad. Dr. Tom Crawford, who was very generous with his slides and helped discuss this topic with me. Dr. Ejima Ekero, who I haven't talked about her, but she was a remarkable person I met at HRS in 2024. And she actually did the first pathway ablation in Nigeria. So she's actually teaching Dr. Edafe a little bit about EP, and he's gradually, they've started doing right-sided pathway ablations. They haven't really been doing a lot of left-sided pathways yet. And Dr. Madu, who is the chief at HIC. Thank you very much.
Kenny, congratulations. That's amazing and inspiring. And so, Sean, can I have you also come up here? But I want to ask you questions first, and I want to take the opportunity to ask you the first question. First of all, I just learned so much from your talk, and thank you for opening all of our eyes to the issues and elucidating your own experiences on the challenges. One of the things that we're working with, that you elucidated very nicely, is this challenge about, the ethics of what is the standard of care, right? And specifically regarding that issue of the reusable devices. I was wondering if you could maybe give your own thoughts on what you think about the ethics of the inequality that exists when there's something that's good but not perfect. You understand the question I'm asking? That we talk about this in the cardiomyopathy space as well. So I was wondering if you could.
Thank you so much. I think that's a really good question. And the idea of that issue of trying to bridge, it's almost sometimes a chasm. And sometimes they say that the perfect, sometimes the enemy of the good. And I think it applies really well in this case. And I think it really worried people like, Dr. Kimegel and Dr. Crawford. And that's why they actually haven't expanded their My Heart, Your Heart program that widely. They wanted to wait for the results of their trial. They wanted to show clearly that they weren't harming people. And I think that's the main thing. When you have a standard of care and you have an alternative to that standard of care, you want to make sure you're not harming people. And you want to be able to tell them clearly that, we've done a trial and we've shown that we're not harming people. And so I think that's where, I see the ethics being resolved. And I think they went about it the right way. And that's why this program has been on for 15 years, but I think it's now prime time for them to be able to expand it, given that they have data. They haven't published the paper yet. I think they're waiting for some more follow-up time to accrue. But at least this first 90 days is a good indication that this is a very possible way to go.
Wonderful. Comments from the audience? Jim, here you go.
Kenny, remarkable work. And, I can't thank you enough for bringing the focus to this. I think it'll be an important avenue for our program as we move forward, and really appreciate your leadership in the space. Can you talk a little bit, you touched on this, so there's the interventional side where you're fixing things once you diagnose them, but there's also the diagnosis part. And we know there are very high rates of hypertension in Africa, for example. We know that there are high rates of a lot of cardiomyopathies that we don't see as commonly here, like peripartum cardiomyopathy. So can you talk a little bit about the opportunities as well? You mentioned this briefly with wearables, but there are very high rates of mobile phone use and smartphone use in Africa at this point, despite the income inequalities. and a lot of opportunities to diagnose as a first step these arrhythmias and then start to figure out solutions. So can you talk a little bit about that?
Yeah, no, that's a very, very important area. And thankfully, diagnosis is becoming easier. So, I was reading a paper that someone said that an ECG machine is $1,000. That's a lot of money in Africa. So it's wonderful that you have at least a 6-lead ECG with a cardiac device that is only like $60 to $80, depending on when you get the sale on Amazon. And I think that's something that is really, really changing the game. I talked with Dr. Ekero, and she was talking about how, people are using Apple Watches to make the, diagnosis. And, there are more affluent people that can afford the Apple Watches. But we now have opportunities to use lower cost devices to actually, implement, to improve our diagnostic capabilities in the country. Because that used to be one of the big issues, that patients never got a diagnosis until they actually became symptomatic. Now they can actually, get diagnosed more frequently. We have a situation where, for example, Dr. Mado is thinking of having ECG clinics in really small towns in Jamaica, like very rural areas. And that's kind of one of the reasons why he wants us to have this remote ECG program, because we're going to generate a lot of ECGs, and he wants some of the fellows to get involved in reading them. And that's something that we're volunteering some of our fellows and who are participating in the program. We're hoping in the future to have stuff like that for even remote echo reading, which is kind of in the works too. And so I think I agree with you, Dr. Freeman, that diagnosis is something that the mobile devices will be a game changer.
And he knows how important I think this work is. I think, one of the opportunities is to also, in terms of bidirectionality, is to understand that the ability to evaluate these conditions in their appropriate context might open up opportunities even for higher middle income countries in terms of new innovations, new strategies. The work obviously that Jim just highlighted is one of them, where a solution can be tested at scale, and the measurements clinically quickly realized, that can be exploited back into communities in the developed world, I guess, is that term. So I think those are sustainable strategies to evaluate and to increase funding for studying these kind of activities with our industry partners, because they do need to run a profit. And so being exposed to those kind of strategies and developing research questions that leverage that, I think is really, as I feel has very good promise. So congratulations. And I'd love to see more of our fellows take opportunities to do some focused experiences in countries like Jamaica and Kenya and Nigeria. I think they come back with amazing ideas. So I have one more question, not to pick on, I just found, your work is awesome. It's an early stage. Do you have a sense of the potential comparative efficacy of different approaches to reduce cardiometabolic problems like NASH or what have you, across these new types of therapeutics versus the ones that are now maybe becoming more established, like GLP-1s? Are you looking at evaluating in these models comparative efficacy across some of these kind of,
That's a very good question. Thank you for that question. It's very important. I think, the reason that I talked a lot about GLP-1 is because it seems to be most widely prescribed, but it has some issues and it's very costly. Patients can't often tolerate it for a long period of time. And so, I think having a cheaper alternative, I think is going to be really important. Something that has less side effects is going to be really important. And in terms of the NASH, or I guess MASH field, I think the studies for GLP-1 and MASH are still pending. I don't know if those are complete yet. I think they're in the process though. And I imagine they're probably going to have some positive effects. I think where I didn't show the slide, but if you look at the pipeline for obesity drugs in the next, that the entire pipeline. It's all GLP-1 plus something else. It's a lot of combination. There's a lot of combination therapy that's ongoing. And so GLP-1 in high doses result in significant weight loss, but maybe can't be tolerated. So if you reduce that dose, this is something that Dr. Shulman and his colleagues thought a lot about as well. But I think everybody in the pharmaceutical industry is thinking about is that you need a combination therapy, whether it's GLP-1 plus something, or maybe something that's unrelated to GLP-1 plus something else. But I think taking a different approach where you're looking at the kind of unifying mechanism of cardiometabolic disease may be the way to go there.
Yeah, I think great stuff, and I'm excited to hear the start that you've gotten off to in your work. But an interesting thing about a lot of these drugs that are for a particular purpose is that we're seeing cardiovascular effects, of course, that we don't totally understand.
Sure.
And there are effects on vascular function, for example, of SGLT2 inhibitors and probably the GLP-1 receptor agonists that we don't really understand. And it's not just weight loss. There are probably direct effects of these drugs on the endothelium, for example, which still is being sorted out. So that's a whole area of potential, investigation there. Not that I'm sort of stealing you away from myocyte biology to vascular biology, but it's not a bad idea. Just to close the loop a little bit, or partially, have you shown that your TLC 1180, was it, or yeah, does that actually decrease pathologic DAG levels and decrease PKC epsilon activation? I mean, has that
That's a very good question. So with the CRMP and the other derivatives, this has been done. But with TLC 1180, I haven't done that. It's in the process, but I suspect that probably gonna have a reduction in SN12 DAG in the liver, at least, with reduction in PKC epsilon. Yeah. But it's a fantastic tool to be able to study all of these aspects of the disease.
Well, we've gone over time already, but we could talk about both of your projects, I think, for hours on end. So congratulations to you both. They're really quite inspiring. And again, my last commercial announcement for the Calabrese lecture on Thursday, as well as we do have the Yale HIC Cardiac Amyloidosis Symposium that you'll all be invited to Friday, June 27th, invitation to follow. So thank you both and congratulations. Really, just fantastic stuff. That was amazing.